Thank you very much, and thank you, Kostas Sparias and the organizing committee for inviting us as doing all these last years. And for this time, I'm going to analyze a quite difficult topic that arises more and more as TAVI grows up. And in order to better define the topic and better explore the topic, we need to have a heart team. Because I have to emphasize, we're going to speak about TAVI in TAVI and left main and coronary artery protection. And the role of the heart team is crucial. Is not only the invasive cardiologists, but is the role of the echocardiographers, the CT, and the anesthesiologist, and all these people. So these are our heart team in St. Luke's Hospital, consisting of a lot of doctors, and we're going to present on behalf of all our team. These are my disclosures. I'm going to present a case. The difficulty with this subject, TAVI in TAVI, it's a new subject, and it comes more and more every day. But there are a lot of things that we need to know about it, and it's brand new terminology actually. And in the next about 20 minutes, I'm going to go through a case and show you what we need to know when we prepare a TAVI in TAVI case, and what is the crucial role of the CT. So let's start with the case. It's an 82-year-old female, chronic smoker. She was suffering from severe aortic stenosis with a moderate LV function of ejection fraction of about 40%. And back in 2018, she underwent a TAVI by using an Evolut 29 millimeter with a very good result, no stenosis and a very mild paravalvular leak. And this is the CT from the first operation. You see heavily calcified valve. You see all the measurements and also what we need to know when we schedule a TAVI in TAVI procedure. We need to get all the information from the first CT, and especially the height of the coronary ostia and the amount of the initial calcification. And this is the procedure. This is a typical TAVI procedure, the aortogram, and the aortogram pre and the aortogram afterwards. You see mild paravalvular leak, but with no significance in AEI index at the time, more than 0.30. She had a regular follow-up, and she was last seen by me back in September 2024. She had a TAVI gradient of 12, a trivial paravalvular leak, normal ejection fraction. She was doing pretty well. And in February 2025, she was admitted with acute pulmonary edema. And we did perform a transthoracic echocardiogram, which showed inverted LV with ejection fraction of about 35 to 40%. And we also noticed severe TAVI, non-coronary, right coronary calcification hypokinesis with a TAVI gradient of 55 this time, and a trivial paravalvular leak. And this was to our surprise, because the same person did the echocardiogram a few months ago. It was pretty normal. But anyway, we had to confront this patient, and we had to manage with this patient. And this is the echocardiogram, which shows, you can see the calcification of the TAVI leaflets, and you can see that the ejection fraction is falling, the LV function is dropping. And actually, within 2 days after admission, the clinical condition rapidly deteriorated. She was intubated, and we had a heart team discussion, and due to all her comorbidities, she was scheduled for TAVI in TAVI. So the only valve that is approved is got CE mark for TAVI in TAVI so far is a SAPIEN valve. So she was scheduled for a SAPIEN. But when we did all the preparation, we need to look a lot of things before we end up with the procedure. So I'm going to analyze you what we need to see and what we need to calculate when we are scheduling a TAVI procedure, and how to protect the coronaries, because the coronaries are at risk when we're going to put a second valve, a second TAVI valve inside the first TAVI valve. And we've got different redo TAVI combinations. The easiest is short in short, but we have short in tall, tall in short, and tall in tall. And it's all about terminology. And I'm going to give you the basic terms that we need to know. Everybody who is doing TAVI needs to know. The first is the nail skirt. And the nail skirt is the region in which the index valve, in our case, the evolute valve leaflets, are fully pinned back. So this will extend from the inflow of the index valve to the outflow of the second valve. And this is an entire column of tissue. And this column of tissue will prevent blood flow and also will prevent catheter passage to the coronaries. So the nail skirt plane is defined as the plane at the top of the nail skirt. And the level is determined by the implant position of the second TAVI valve. So we need to know exactly from the CT the nail skirt plane where we're going to put our second TAVI valve, and also the relationship of this nail skirt plane to the native anatomy, the coronary ostia, the STJ, and the aortic wall. In short combination, the nail skirt plane is a single consistent level matching with the top of the leaflets, and it's quite easy. But when we have short and tall combination, we may have multiple levels of nail skirt plane, and we define an upper and lower limit. Upper is the one with a minimal leaflet overhang. We'll explain what is leaflet overhang later on. And lower is with acceptable leaflet overhang. And the coronary risk depends on the depth of the index valve and the depth of the second TAVI that we're going to place. So in tall and short combination, the nail skirt plane will be at the top of the leaflets of the index valve. In tall, the nail skirt plane will be at single consistent level equivalent to the top of the leaflets of the index TAVI. Now, the other term we need to know is the coronary risk plane. What is a coronary risk plane? It's defined as the level at the base of the lowest coronary ostia. So identifying the level of this plane in relation to the nail skirt plane is vital in pre-procedural CT planning. And there is another term, it's called VTA. VTA consists of three measurements. The first is the valve to coronary ostia, VTC. The second is valve to aortic wall, is the distance from the TAVI to the sinus or aorta wall at the level of the pin leaflets. And the third term is the VT-STJ, which is the distance of the valve to the STJ junction. And all these measurements need to be done very carefully by the CT. So when to measure? When the nail skirt plane is below the coronary risk plane, so there is no problem. There is minimal or no risk for the coronary, so it's quite easy. But when the nail skirt plane is above the coronary risk plane, then we have to measure. And if the nail skirt plane is below the STJ, we measure the VTC and the VT to aortic wall. If the nail skirt plane is above the STJ, then we need to measure the VTC, the VT aortic wall, and the VT STJ. And all these terms are called VTA. And there is classification. The VTA is more than 4, then we are okay. If the VTA is between 2 and 4, is intermediate risk, and we have to consider protecting the coronaries. If the VTA is less than 2, then it's very risk, and then we may need to consider different modes of treatment. Another term we need to know is sinus sequestration. And what we mean with sinus sequestration is when the nail skirt is above the STJ, then if the VTA is less than 2, as we said before, we may have sinus sequestration and we may have obstruction to the coronary flow. And you can see here an example when we do a TAVI with a short TAVI in a second short TAVI. And here again, sinus sequestration, when we perform a second balloon expandable in a first tall TAVI. Leaflet overhang. Leaflet overhang is the portion of the index TAVI leaflets that extend above the second TAV. So you can see when we perform a TAVI, a sapient TAVI in an evolute, depending on the height of the second valve, there is a various leaflet overhang. And what is the meaning of the leaflet overhang? If we have minimal leaflet overhang, we don't have stenosis. If we have more leaflet overhang, we may have more stenosis from the leaflets of the index of the first valve. And also we have to realize that the neoskirt is a static column, whereas the leaflet is a dynamic part. And when we are trying to manipulate the coronaries, we have to know where to go according to the leaflet overhang. Another term we need to know is commissural alignment. And we all know what is commissural alignment. We need to know the first valve, how well aligned is with the coronaries. And we all know how to perform now commissural alignment, but in the earlier ages of TAVI, we didn't know that. And we know that if the commissures of the TAVI is well aligned with the commissures of the native aorta, then we don't have obstruction to the coronaries. Whereas if we have misalignment, then we have more difficulty with the coronary access. So going back to our case, here are all the measurements. We were opting for a sapient 26. The VTA above the left coronary was 2.4, so it was a quite risky case, risky for left sinus sequestration. And we selected node 5 of the index valve in order to avoid leaflet overhang. And the node 5, the neoskirt when we put a 26 S3 in a 29 evolute, is 20.6 millimeter. So in our case, the left coronary artery height was 18.3, so it was between nodes 4 and nodes 5. And the RCA height was above the neoskirt plane. So the neoskirt plane was above the left coronary risk plane and below the level of the right coronary risk plane. So we had a problem with the left coronary system. And although the VTC was quite good, was more than 6, and the evolute R was quite well aligned, the VTA was less than 0.24, the left VTA. So that means that if we didn't protect the coronaries, we would have sinus sequestration and we would have obstruction to the left main. So the decision was to perform TAVI in TAVI with a Sapien Edwards 26 at node 5 to avoid leaflet overhang and to protect the left main with the chimney technique. And I'm going to show you what we need to do with the chimney technique when we are doing TAVI in TAVI. It's quite different from doing chimney technique when we're doing just the first TAVI. And this is because we have to use guide extension. We have, in order to avoid interaction with the first TAVI frame, we have to select stents with high radial strength. We have to position the stent inflow above the second TAVI frame. And we have to keep the stent balloon in place after deployment in order to reinflate after the second TAVI implantation. And in order to do this, we have to use the guide extension and to advance the guide extension over the stent balloon. Sometimes we have to use IVUS in order to assess the stent and post-dilate according to IVUS. So this is our case. You can see by this orange level where is node 5. So node 5 is just above the left coronary wrist plane and below the right coronary wrist plane. So initially we protected the coronaries. We performed, we used the guide liner, we used the six friends guide and the six friends guide liner. We put the guide liner, advanced the guide liner inside the left main. She had a severe LAD stenosis. We fixed this first. And then we left the guide liner inside the left main. We disengaged the guide catheter above the level of the evolute in order to have better, in order to be able to perform the second TAVI. And we advanced a strong stent, a Megatron 4.5 inside the guide liner. And then we parked the Megatron stent inside the left main with the guide liner inside the left main. And we continued with the Sapient deployment. You can see that we tried to be at level Node 5. In all these cases now these days, in order to avoid movement of the second TAVI, because it's more easily, we have to be very accurate with the position, we intubate the patients and we stop breathing. Apart from the very rapid pacing, we stop breathing when we deploy the second valve in order to be as stable as we can. So this is what we did. We can see the TAVI deployment with the protection of the left main. Here's the deployment of the TAVI, and it's just above the ostium of the left main. So this is post-TAVI deployment. We bring the Megatron stent above the inflow of the second TAVI by removing the guide liner. We deploy the Megatron stent as planned. And then we post-dilate it with a 5-volt balloon at 26 atmospheres. We need to do strong post-dilatation. And this is the appearance post-stent deployment. Very good stent apposition without any stenosis. And the final aortogram, both left main and right coronary artery are fully patent. There is no aortic stenosis or aortic regurgitation. And this is the transesophageal. Because we intubate the patients, we do transesophageal, and this is the picture with a mean gradient of 6. No aortic regurgitation. And before discharge, we analyzed again with the CT, and we had some very good pictures when we can see the stent with no stenosis. It protrudes above the Sapien valve and with very good apposition. And you can see these images provided by our radiographer, and it shows the TAVI and the stent according to our initial plan. The patient was discharged day 5, class 1. She was followed up at 3 months. She is still class 1. So in concluding, TAVI is a very good solution, but we need to be very careful. We need to have a meticulous CT pre-assessment. There is need for balloon expandable valve. The precise and accurate position is mandatory, and we should always consider how to protect the coronaries. Thank you very much.
Petros, congratulations for excellent presentation and the case. In these complex cases, I think that the importance of heart team is
exactly.
Yes. A question: if you had the ability to imagine the future for the patient, did you have changed anything in the first procedure?
Well,
valve, other?
Yes, that's a very good question. And these days, when I have patients less than 80 years old or patients who are prone to coronary artery disease or who already have coronary disease, I always put a balloon expandable valve.
Thank you. Any comment, any question from the, yes?
Mr. Dardas, this is Michalis Koutouzis. How are you doing?
Yes, Michaeli.
I would like to ask you, you did a great job and you protected the left main, but why did you expand the stent before checking if the left main was obstructed or not? Because if there is a danger, you put the stent in order to have it there to be safe, but if there is no obstruction, you don't have to deploy it.
Okay, thank you very much. Very good question. Now, this was all pre-scheduled. And when we put the valve, when in the CT you put the valve and you try and you measure, there would be definitely an obstruction. So you saw that the inflow of the sapien valve was above the coronary, and we would have problem. If we wouldn't have problem at that time, we may have problem in the future. So we had to protect the left main. It was a pre-scheduled decision.
Just a comment from me, a word of caution. You're absolutely right, because all your planning so that if the valve was going at the STJ or above, there will definitely be an obstruction. And I think a coronary angiogram at that stage, Michali, might fool you. So you might see some flow into that left sinus of Valsalva and say, oh, I don't see a stenosis. But this flow certainly will be low flow, low velocity flow, so you'll transform an aortic area into a venous area. And this will be high risk of thrombosis and then embolism in the coronaries. And this is something that has been reported many times. So I think this planning, the city planning, must be very accurate. And I think if there's a question about the outcome from the city planning, you should stent. And you rightly did that. The only problem, I see this is an excellent result of what we're going to do more and more over the next years, because there are a lot of self-expandable valves around and supraannular valves around that in the future we'll have to do this very often. The problem, the only downside is that if you have to go into that left main for coronary intervention, that would be extremely difficult, if not impossible. So that's the only problem I see.
Yes, I understand that. And well, we haven't come across this problem again. And but okay, for chimney, it's difficult to re-engage. But you can go either fishing the ostium or go from the side. That's why we select big stents, we overinflate them, and you can go from the side, actually, and create a new ostium. And as far as the Michalis question, I have to emphasize that it's different when you protect the coronaries when you're doing your first TAVI, and it's different when you're doing TAVI in TAVI, because in TAVI, if you don't pre-select to put the stent, and say if you may do an IVUS and see how is the flow, but the positioning of the stent afterwards, even if you have a guide liner, is more difficult, because the two surfaces of the index and the second TAVI valves are next the one to the other, and then you may scratch the stent. So in this case, it's always better to have pre-schedule this beforehand.
Petros,
yes.
Sorry.
Yes,
go ahead.
Petros, in your opinion, what is the major problem in TAVI procedure?
Well,
generally speaking, the protection of.
I think yes. I think it's the protection of the coronaries, because if, say, yesterday I did a case again with an evolute valve that actually, to my surprise, the 2 leaflets here were torn after 4 years. It could be product failure. But anyway, and this patient had a previous CABG, so I was not concerned at all. I put my valve where I had to put it. I had an excellent result. I didn't mind about the coronaries. It was about 10 minutes job. But when you have to protect the coronaries, it's a different issue.
Kostas?
You have to be very
Another
careful.
question, Petros?
Another word of caution, Petros, in this case is I think you were lucky. It was by chance that you were able to inflate a stent between 2 very strong metal struts from the core valve and the sapien. If by chance your stent was sandwiched between these 2, it'll be extremely difficult, if not possible, if impossible, to dilate it, and you'll be in trouble. So you play by chances, even after this very well planning and scheduling of the case. So I think in the future there will be a difference between TAVI and TAVI in an evolute valve than TAVI and TAVI in an accurate valve, because in the accurate valve you don't have metal to the back of the leaflet. So it will be easier to put a stent there and sure that it will be dilated. With evolute and less with Navitor, because Navitor has much less metal than evolute. This would not be guaranteed that it will be possible. So I think as we're doing more and more of these cases, we'll go into this much details, and one day we'll do a case like your case, and you'll see that it won't be possible to inflate your stent. And then there might be a problem.
Yeah, let me answer this. Very good. This is our concern, that the stent is got like a sandwich between the 2 metal frames. But there are 2 issues. The first is that, of course, we use the guide liner, so we don't put the stent inside the level. We retract the stent, so we position the stent exactly where we want to do it. And the second is that we use a very strong stent. I think Megatron is the strongest stent with a very strong platform, and we inflated at very high atmospheres. We went 26 atmospheres with a 5-hour balloon. And this actually overcomes the issue that you said, and we showed it very clearly in the CT that we performed a week later, that the stent was fully expanded.
Dr. Dardas, thank you very much.
Thank you as well.
Yes, next. Thank you.